With that, I'd like to introduce our chair and moderator for the next session, who will in turn introduce our next stellar panel, and Dr. Pierre Vigilance, who I've gotten to know in the blockchain and healthcare space over the last couple of years. So I was delighted both when he came on board as an advisor for ConsenSys Health, but he does a lot of things, and he is the founding principal at HealthUp and an adjunct professor at George Washington University. And he's going to be leading us in this panel, and we'll introduce these absolutely stellar guests that I'm glad took the time to join us today. Pierre, over to you.
Thank you very much, Sean. Can you hear me okay?
I can hear you.
Excellent, excellent, excellent. Well, I'm very, very happy to be part of this day of conversation around veterans' health and some of the gaps that are existing in the perceptions that we have, issues that our veterans have, and also in the services that they are provided. And I have this distinct pleasure and honor of introducing you to this fantastic panel. We're going to be discussing a few really interesting topics. I think during this next hour is going to fly by. So again, my name is Pierre Vigilance, former Associate Dean for Practice at UW School of Public Health and former Health Commissioner for the District of Columbia, now operating in a bit more of an independent space, still teaching a bit, but very much engaged in work at the intersection of health, tech, and the social determinants of health. So doing a number of different things in those sectors. So this is a conversation that I've been looking forward to. We're joined today by four panelists, and the first of whom is Dr. Lynda Davis, who is the Chief of Veterans Experience Officer at the U.S. Department of Veterans Affairs. We're also joined by Jackie Garrick, who is the founder of the Whistleblowers of America and the founding director of the Defense Suicide Prevention Office. Thank you both for joining us. We're joined also by retired Brigadier General Loree Sutton. Dr. Sutton is the former commissioner of the New York City Department of Veterans Services, and also by ConsenSys Health's very own Dr. Alex Cahana, the Chief Medical Officer for the emerging market leader at ConsenSys Health, and subject matter expert for defense and veteran centers for integrative pain management. And we're going to be talking about a few different things related to the gaps that exist in experience from the perspective of health professionals with respect to veterans. And we're going to just jump. Thank you all very much for being with us today. I wanted to actually give you each an opportunity, if you would, to just, because I think we have time to do this, to just talk a little bit about sort of, introduce yourselves and talk a little bit about your primary sort of takeaway, if you will, from an experience perspective. We talk about from the perspective of providers with respect to gaps in care before we get into the conversation, because you may have some pretty interesting perspectives to start us off with that will then blend in with these questions. So if you wouldn't mind starting us off, Dr. Davis.
Well, thank you very much. And it's a pleasure to be on this distinguished panel, which I will say distinguished not me, but my colleagues who happen to also be great friends in this community that we share for our veterans, families, caregivers, and survivors. Thank you for the opportunity to address this important topic. First of all, I think we have to, I need to start by frankly challenging the assumption in the title, gaps in care. In that, I would want to, I think all of America has a heightened attention to what we might determine to be gaps in care for all of our civilian as well as our military and veteran populations and those who love them. I would not want to thus presume that there are only gaps in care within the veteran community. But I would like to, with these other panelists, share what we perceive those may be and how we're intervening. So I can only speak from the VA at this point. I've had the honor of working with two of the ladies, at least at DOD in prior years, and know there is a connection between what we do at DoD and VA across the lifespan for the veteran. Let me just say quickly a couple things we're doing. At the VA, you mentioned the word experience. The very first thing, my responsibility for the entire enterprise as the Secretary's #1 priority is to understand, listen to, and translate the experience of the veteran family caregiver, their survivors, and our employees into actionable activities that we can take to improve that experience when we determine that it is not up to the high quality that we want. When in healthcare, that means we have a high standard for a highly reliable organization. The way we do this listening is through very different multi-channels, including under my office, the Veteran Signals surveys. We're doing our extensive 1,000 contact centers and how we've integrated those, including the White House VA hotline, how we're using chat, text, chatbots, etc., to make sure we're regularly understanding and including boots on the ground through our community veteran engagement boards, what is in fact the healthcare experience of veterans. And I'll be glad to share with you through our 3 specific COVID-related surveys what we are hearing. I will be remiss, and I hate to get off topic, but the prior panel specifically raised a couple key concerns about what we're doing with children and youth, and also about data analytics for those at risk. 2 things are going on through my office, and I will want to at some point come back to those. But thank you very much. Glad to share what we are doing when we identify the concerns of our veterans, which I have the data on. I also have the interventions that we're doing.
Excellent, excellent. Thank you for that. Jackie, from your perspective, and sorry, Dr. Davis, thank you for not so much the correction, but the commentary about not just gaps for veterans, but gaps for all populations, because we are seeing those very much highlighted by COVID at the moment. So I appreciate you making those kind of one and the same.
And our veterans also are getting all their care in the community. They have the choice option now. Right. So we need this to be a 2-way learning experience.
Absolutely, absolutely. Jackie, welcome. From your perspective, a little bit about you, about you and your background, and maybe how it lends itself to this conversation related to the topic of gaps just in care in general, and from your perspective, then we can go to Dr. Sutton.
So I have found this to be a very interesting request this morning, because I always have to think about which hat am I wearing when I answer some of these questions, because I've walked this all the way around the block. I've been on active duty as an Army social work officer. I've been at the Pentagon. I have been a patient at the VA Medical Center, so I'm a VA user. I'm a family member, and I started Whistleblowers of America in 2017. We have done over almost 600 cases at this point, but half of my cases are VA employees. So I have talked to over 300 VA employees in the last few years about what their experiences are like to try to provide care. And so I feel like there's this opportunity here to, and what Lynda was talking about, looking at this experience, but looking at this 360 experience. Like, what is this like for everybody, for when we're patients and users of the system, and also when we're providers of the system. One of the things that has just stuck with me when I talk to providers is just how much of the time they feel with their backs to the patient, because they're so busy answering alerts in the system and that's about their jobs and their promotions and their chain of command. So they're constantly going through this emotional conflict and this ethical dissonance of, am I taking care of my patient? Am I taking care of my system? Am I taking care of my own family? Because if I don't do these things, will I be a good doctor? Will I lose my job? So there's this continuum I see from these perspectives that we need that pull through so that everybody feels involved and engaged in that experience so that we are maximizing it and making it the best that we can make it. So with that, I'll let, I guess Dr. Sutton is next to introduce herself.
Yes, thank you, Jackie, for that. Dr. Sutton, welcome, and thank you for joining us. So we just, the question on the table really is just an opportunity for a brief introduction and your perspective on this topic of gaps in care writ large before we get into the questions themselves. So from your perspective, we'd love to hear any thoughts that you have.
Loree.
Microphone.
How's that?
Good?
Okay. Pierre, let's start over again. Thank you so much. It's great to be with everyone today. And Jackie, so nice to see you. And of course, Lynda, always great to see you. I have to say that this is what no push-ups needed.
Are we strong, ladies?
There you go. I got to tell you, this is one of those mornings when you just got to adapt, improvise, and overcome. So it's just great to be here. I'll just say one little thing. Some of you may have realized, some of you may have seen that I looked a little bit like an impressionist painting earlier in the session. My Loree had gotten me one of those blue screens to put on and protect my eyes. I hadn't taken the little bubble over the camera out. So, okay, with that, let's go ahead and get started. Gaps in care. Let me start out by saying that I think for those of us who are involved, who have the privilege of working with veterans and their families, working within the VA system, working in partnership and with our civilian healthcare system, this is a time for us to partner like we have never partnered before. And I know that, you know, this has been a time of reaching out as community groups, as government agencies, as healthcare professionals. And I would just say, I think one of the biggest gaps in care would be that involves all of us as care providers. And I would just want to make sure, I know here in New York City, we've had several suicides now over the last few months. You know, many of you are certainly aware of the Columbia Protocol. That's why I wear it around my wrist, to be able to share with folks the 6 simple questions that will identify who's at most imminent risk. So let me just stop there, but I'd love to unpack that a little further in terms of how we can really reach out and be there for each other as care providers and keep our own wells full so that we can care for those in our charge. Back to you, Pierre.
Very, very good. Thank you, Dr. Sutton. Appreciate that. So I wanted to sort of kick off with this opportunity to sort of just...
Pierre, this is Sean. I'm sorry. Just to let you know, we do have Dr. Cahana on audio. He just does not have...
Oh, thank you for telling me that. I'm sorry, Dr. Cahana. I was going to completely omit you. You know, in these COVID Zoom days, if we don't see faces, then we're sort of missing people. So, Dr. Cahana, how are you? Sean, is Dr. Kahana's audio working, or are we?
Dr. Cahana, you may be muted. Oh, okay. Or perhaps we have lost him.
No problem.
Dr. Cahana, if you can hear us, knock twice. I joke. No, I apologize. It does look like we've lost him. We'll try and get him back again. Randall's working on that behind the scenes, but please, Pierre, carry on.
No problem. Thank you. So you all are engaged in, and we're going to pivot I really appreciate the commentary about both the veteran population and the civilian population, and the systems both needing to be in play to be functional in a very comprehensive way. And thank you, Jackie, for your commentary about wearing different hats and being a patient, a provider, a veteran yourself, etc., and having the experience of all of those things and being mindful of those experiences as you provide care or as you provide service, or both. But looking at or thinking about the care of service members and veterans, as you think about their health and well-being, sort of what's the thing that keeps you up at night? I mean, and I know we might be here all day with respect to that question. So what's the one thing that primarily right now has sort of got you thinking, okay, we really, really need to address this particular thing? And I'll start with you, Jackie. Is there something that you would highlight as being a key issue that is currently in need of addressing, or a change in approach with respect to our veterans and their health?
Okay. And I apologize, I live in Pensacola these days, and apparently the Blue Angels have just started their flight path training. So there's going to be maybe some background noise. I apologize. It's not the hurricane. It is a bunch of aircraft overhead. So I think, though, besides all the noise that keeps me up, the trajectory towards suicide is something that I have spent my career looking at. The first time I presented on suicide, it was 1990. Suicide was the 10th leading cause of death in America. Well, it's still the 10th leading cause of death in America. So for everything we've said and done, in 30 years, we really haven't moved the needle. And that spans administrations, politics, all kinds of different interventions and viewpoints. So what I see, and when I think about the gap here, is, and I'm a old Deming School Plan, Do, Check, Act student. So what I think about the suicide data that we know, and that the VA and the DoD, I know Lynda and Loree, we the three of us have worked together a lot in the past. So this is almost I have to remember that we're not just having a conversation amongst the three of us, that this is going out to a broader audience, because I'm so familiar with these two lovely faces in front of me, and of course, Pierre, you're lovely too. I just haven't met you before. But when I think about that data and what we know and what we've looked at, and I know Rajiv and Christy earlier were talking about the data and how much we collect and propensities and probabilities, and I'm at a point where I know we can do a lot more with predictive analytics and how we use that kind of data. But also then we have to take that bucket that has all that data in it and be able to draw the string as to where does Congress put its money, how much money gets allocated, and not just allocated but spent, because in the last few years when we've looked at the difference between the appropriation, the obligation, and the execution, we've seen a gap of about $30 million that never got spent. So it got appropriated, it didn't get spent on suicide prevention. And then we have to look at what those programs are. What are we doing? And that's the slide I had wanted to share was the IOM protractor. I spent most of my career on the prevention side, and then the treatment side, and then another part on the rehab side. But when you look at that first wedge of the protractor, and we talk about things that are universal, selective, and indicated, we spend a lot of time and money on the universal. Because messaging and videos and posters and billboards, all that's very sexy stuff to do. But when it comes to then being more selective and indicative, we close the fan, I think, a little too much, because we do what Colonel Castro used to call the low-hanging fruit. We do what's universal, but like when I looked at the last Prevents report that came out from the VA and all of the federal government, it didn't mention once bed days of care and inpatient care, which when we hear about veterans going to VA hospitals seeking care, they get turned away, and then they die by suicide in the parking lot. Those are the things that truly concern me. And then I think the being able to match up the right treatment for the right patient. We rely a lot on cognitive behavioral therapy, but if you've got a TBI and you're cognitively impaired, is that going to be really the best intervention? So these are the things that mismatching of the data, the money, the program, and then of course the outcome is where I think we fall short.
Okay, and I'd like to then pivot now, because you gave us that very good clinical piece there. If I could talk to Dr. Sutton, ask Dr. Sutton for your take on what keeps you up at night, and then I'll come to Dr. Davis, and then Dr. Cahana's joined us online. Dr. Sutton.
Thank you, Pierre, and thank you, Jackie, for your comments. You're right, we have worked together for many, many years, and sometimes, you know, it's so important to just be able to draw support from each other, knowing that we still got a lot of work to do and a long ways to go. What keeps me up at night is related to what you were talking about, Jackie. Specifically, it's social isolation, and particularly in a time of pandemic and the financial collapse, and now we're in the middle of the reckoning, racial reckoning, which has been long overdue. I worry, though, that our veterans and their family members may sort of withdraw and retreat in the midst of all of this. And I think for any of us, whether we're working in the clinical world or whether we're working in community, whether we're family members, veterans ourselves, whatever we can do, even during and especially during these times of social distancing, we have to make the extra effort to connect, to stay connected. We know, of all too many folks who have survived suicide, thankfully, but who have said, it was that one person who just said something to me when I was on the bridge that morning, that one person who reached out. And so, I can't remember who said this, but I love this quote: be kinder than necessary, for every person we meet is fighting some sort of battle. Over.
Absolutely. No, that's very, very good. Dr. Davis, you deal with this from a similar perspective to our last two speakers, but the experience that people have in care or in any of the services they acquire obviously is highly impactful to the outcomes that they have. So from your vantage point, what is it that sort of causes you sleeplessness?
Well, I appreciate Jackie's laying out many of the multiple factors we need to concentrate on, and Loree going into one very real challenge of isolation. Somewhere in the middle is where I find myself right now in this particular hat that Jackie referred to. So at VA, I'm responsible for customer service. And that means I do the data analytics on over 42 surveys, which have resulted, we get regularly in real time from veterans, 30 million surveys we've received back with 5 million comments. And we need to analyze those not only for trends and changes by facility, et cetera, if we're talking about care, but we need to look at them for specific service recovery opportunities. That's why we're looking at not only quantitative, but qualitative. Those 5 million comments give us an opportunity to intervene. It keeps me up at night. Are we attending to the needs of those individuals that we know are at risk? So whether it's through these surveys, through the White House VA hotline, through other sources that we have, how are we connecting ourselves in the VA to make sure that we do attend to those at risk and do service recovery? A few quick things. We have the link to, for those who are at risk and any indication that we get through their surveys, we are doing data analytics, AI to scrape keywords that indicate somebody is hopeless or somebody intends to do harm. Those have an immediate reference for the VA crisis line for the warm handoff and the attention that they need. We've had hundreds of those that have happened and that have been able to help save people's lives. The same thing occurs on the White House VA hotline, that warm transfer, not only to the crisis line, but the homeless line. So we're looking at ways to do immediate interventions for those most at risk. That's one population. It was mentioned that our service providers themselves, frankly, are at risk. They are challenged in their workload, in the time, et cetera, et cetera. So we have a whole patient experience intervention that has been going on for several years, which has resulted in our SHEP and sales scores outpacing the private sector. That is where we're doing interventions of things like over 100,000 VHA employees have been trained in Own the Moment. They're doing things that are enabling them to have additional assistance with the technology that they have before they greet a veteran. They know best how to engage the veteran, and they're seeing the story from the veteran, my life, my story, recorded, so they can understand the real nature of that person's personal concerns, and they can personalize the delivery of medicine. The surveys that we had, we collect not only concerns from veterans for service recovery, but compliments and recommendations. Those compliments are being shared at during rounding at the medical center level to let employees know that the veterans love them. And most of our comments from the surveys, which are voluntary, of course, are compliments. The other thing we're doing, so we're supporting those at risk, the employees. One of the other things that we're doing quickly is addressing the concerns of those who love and support our veterans, their families and their caregivers. During the COVID experience, we shared almost 7,500 Facebook portals that were donated and distributed by the Red Cross MVCN to veterans and their caregivers to make sure they could communicate. Not all caregivers are in the same location physically. I'm caring for two people, one in the house and one a little bit farther away. They need interactive mechanisms. So we had that collaboration and partnership. We also had the Operation Gratitude packages that went directly to our providers to reinforce the appreciation for them. We've donated Amazon Prime through them. We've donated 1,100 disposable cell phones for homeless veterans. So we're using our partnerships to reach out and do things for all of our populations. Lastly, around the isolation, and Loree, you had an opportunity to serve on our Veterans, Families, Caregivers, Survivors Federal Advisory Committee, chaired by Senator Dole, and I thank you for that. That committee and the new Center of Excellence for Veteran and Caregiver Research is specifically looking at the challenges of children and youth who oftentimes are the caregivers of a wounded, ill, or injured, disabled, chronically ill veteran. And we're looking at that not only with research, but we're looking now at events that we can do to ways in which we can understand and then support them. And that support may not always come, as Jackie alluded to, through authorizations or appropriations, but maybe we have to do interagency collaboration. The DoD knows a lot in this area, a lot more than we do, but also HHS. So we're working with the Administration on Community Living to make sure those networks in the community that support the young, that we are able to address what are the challenges they face in isolation, their potential risk for mental health, even for suicide, as their caregivers, the caregivers of the veterans, are also at risk. And we're in fact have a live event going on coming up for back to school and addressing children and youth, I think tomorrow. So we're trying to look at the different customers that we have, which are multiple, including our employees, and making interventions. We've got a whole list. I have a whole list of the kinds of things that we've been doing to address the moments that matter for veterans during COVID. And the analysis of their comments on the surveys, the 3 surveys that we have from them. I don't want to, though, just hear from what the concerns are unless we can be responsible for service recovery and intervening, then we're only getting half of the job done.
Right. And I do appreciate all the comments that are being made, particularly those, as Dr. Sutton drilled down to that social isolation piece, and then the commentary about the need for the warm handoff to service providers who may not be clinical. There may be other areas of non-clinical support that are necessary that are within your immediate reach, if you will, within the VA, but also external to that. But I think that this raises questions for me about, how are we identifying and maybe providing access to coping skill bolstering, if you will, to some extent, because people, as they deal with some of these challenges of isolation, and COVID is certainly not helping with any of that, but as they withdraw, I think as Dr. Sutton very specifically stated, the methods that we might turn to may not all be the most healthy. And so we may be at risk for falling onto or getting onto a slippery slope with respect to a number of different things, alcohol, for example, drugs, etc. And so I wanted to sort of pivot slightly and have Dr. Cahana join us. He has a particularly great area of expertise in pain management, and as a result, obviously some knowledge with respect to substance use. I wanted to see if Dr. Cahana, are you on the line?
Yes, can everybody hear me?
We can. Excellent. So we were talking a bit about pain points and sort of what keeps people up at night from your individual perspectives with respect to veterans and their health. And we've heard a few different things from the finance and policy end of things. Allocated funds are not necessarily spent funds for particular needs, particularly as Jackie commented on with respect to suicide. And then we went deeper in with respect to the social isolation element of things, and then the services that are provided and the customer service element of things. And I really liked what Dr. Davis was talking about with respect to qualitative data being just as useful and I might say more useful to some extent in certain circumstances than quantitative data. But pivoting back to this social isolation piece, and also to your general comments, Dr. Cahana, about what keeps you up at night. How do you react to that particular question with respect to our veterans population?
Yes, thank you, Pierre, and again, thank you for all the group. I've been listening to the whole conversation, and what kept me awake was not being able to dial in or to have a picture. So, no, but in all seriousness, just for 30 seconds of my background, after 16 years in Special Forces in the IDF, understanding that none of us is as good as all of us, and the importance of teamwork and distributed trust, I had a full career of over 28 years in pain medicine, building 5 pain departments in 5 different countries, and was very privileged to work with the DoD VA Joint Pain Task Force that came out of the NDAA from 2009, and was part of the creation of the Defense Veterans Center for Integrative Pain Management. And so this is almost, I think, the first time that I've joined a team or a group that understands that the opposite of health is not disease, but isolation. That when I talk to 99 people out of 100 and say, what is the opposite of health? They would say illness and disease. And that is why in our country, we have a disease management system and not a healthcare and wellness system. And when I explained that that is incorrect, and I remember in one of my congressional testimonies, I was saying asked that question and then corrected and said that it's through disease and illness that we get isolation. And so if you bear with me and agree to that line of thought, then the journey back to wellness is through connectedness. And that connectedness could be to family, friends, your own data, community, faith, virtual communities. So the way I explain to my 14-year-old is that if you replace the I and the word illness with we, you get wellness. And so this is a very, very, I would say, sophisticated and elevated conversation that I want the audience to make sure that they don't take this for granted, that this is a blind spot among most policymakers, among most regulators, most legislators, and it's only when they hear it, they get to that aha moment, and we should kind of continue and spread that word. Now, in terms of your specific question of what keeps me awake at night, and you're absolutely right that we are not suffering from an epidemic, but from a syndemic, a combination of epidemics, the epidemic of opioids, substance abuse, alcohol, smoking, isolation. We can go on and on, all the chronic non-communicable diseases, and what COVID has shown us also communicable diseases. And so what keeps me awake at night is that the system is not broken. When people say, oh, we need to recover, I don't like the word recover because it means that we're covering up again. When people say, oh, you know, we need to go back to normal. No, it's what's the normal was got us into this situation. What keeps me awake at night is that the system is working exactly as it is designed to work, and that it is a fragile system that is not prepared for the digital age. And it is designed in a way that creates so much friction that we have lost that peer-to-peer connection, that soldier to soldier, veteran to veteran, professional caregiver to family, because there's so many intermediaries. And that is why I work at ConsenSys Health with these cutting edge technologies to enhance it. So what I would suggest, and I'll end here, is that we need to transform our veterans from health service consumers to health producers. And so we should stop talking about being patient-centric or veteran-centric and make it veteran-driven. And now we have the technology to make it driven. And you know, Pierre, we have these conversations between us multiple times, where distributed ledger technology, where federated learning, where all these kind of ways to create actual tangible assets where people can be rewarded for healthy behavior. And when I say rewarded, I mean money, I mean hard cash. Because I don't recall getting a check from my payer last week for not using OxyContin. So the point being that we need to really be creative, and we need to think seriously, not about optimization and how to make things more convenient, comfortable, quicker, nicer, but actually to really redesign and make this a patient driven system where they are sovereign to their data and that they are rewarded and incentivized through actions that enforce their solidarity with the community. Because although we are physically separated, I don't like calling us social distancing, so I call it physical distancing with social solidarity. And I'll stop here.
Excellent, excellent. Thank you, Dr. Cahana. And I think, so why I love having these conversations is because I get to put together a list of questions and then crumple that piece of paper up and throw it over my shoulder, because the richness of the commentary presents the opportunity for maybe some different dot connecting. And so so those of you who need that list, I'm not going to completely go rogue, but I am going to sort of merge a couple things, because I think that we have a limited amount of time left, and I wanted to make sure that we honored the richness of this conversation. And I wanted to see whether or not we might talk a bit about the partnership opportunities, because I think that what Dr. Cahana was just referring to with respect to systems, and the system is working, the healthcare system is working exactly as it should. And I like to say that health is more social than medical. I've been saying that for a long time. People say to me, well, you're a physician, how could you say that? Well, it's because, 80% of our health, if you will, 80% of our wellness is not sort of taken care of by the healthcare system. The healthcare system is not designed to do that. That 80% is taken care of by other things, right? Our social interactions, our social system, transportation, housing, access to technology, economic development, all these different elements. And there are service providers in those spaces that needs to be functional and capable in the work that they do. And so if we're going to be able to partner with them, that's one thing, but to be able to partner with them and get great outcomes from their partnership is key. So I wanted to see if I could come back to you, Dr. Sutton, and talk, because from your perspective, a lot of mental health care is being moved out of institutions and into the community. That has been a movement that's been going on for the longest time now. Partnerships, though, with respect to mental health care in the community can be difficult. There's a limited amount of resource out there for that. How have you, or what are you aware of with respect to movements that are afoot to improve that level of access, so that when Dr. Davis is providing that experience continuation outside into the civilian population, that it's there? I mean, what is your sort of commentary on raising the level with respect to mental health provision specifically and partners out in the community?
Well, thank you so much, Pierre. And let me just take a moment. Alex, thank you so much for your comments. I love that. Replace the I with we, and it's wellness. That's so great. And the social solidarity. It's always fun when you learn something new. And they say that, we used to think, when I was in medical school in the dark ages, we thought we were born in this life with all the brain neurons we're ever going to have. And now we know that there's neurogenesis, and particularly when we start learning new things every day. So thank you, Alex, so much for helping our neurons grow a little bit further today, and to give us, again, that perspective, that team of teams perspective. Understand that true stronger than strong strength comes through those peer-to-peer survival relationships, and that when it comes to mental health, yes, isolation kills, community connects. And so, a few years ago, and this is when Lynda, I have to say thank you so much for the work that you are doing. That's one of the things that helps me sleep better at night, just knowing that you and your team and Senator Dole and the Federal Advisory Committee are really paying attention to the needs of families, caregivers, survivors, because we know that that has a direct impact on the mental health of our veterans and our extended community. Let me just say a couple of things, Pierre. The last 3 years that I was serve in uniform, 2007 to 2010, when we put together the Defense Centers of Excellence for Psychological Health, Traumatic Brain Injury, we invested, we went far beyond the medical model. We realized we needed to invest in resilience. To the left of the recovery model, we needed to invest in reintegration. So part of what came out of that, when I 5 years ago started here in New York City as Veterans Affairs Commissioner, at the city level, we realized that we knew enough about what worked, but we didn't have a model. So we put together what we call the whole health core 4 model. And I don't have a slide of it, but just imagine, kind of like the food pyramid. And at the base, C1, you got culture, inspiration, and the arts. Our lead community partner was Brian Dories and his Theater of War program. And for any of you who are interested in how that work has continued to develop, just look up his website, Theater of War Productions. It's awesome. C2 is connection. That's the peer-to-peer connection. That's the optimal point of entry for the model, because once you have that peer-to-peer connection, then you're not alone, like Jackie said earlier. You've got somebody there who's perhaps a little further along that journey of wholeness and healing and health. C3 is the bridge. That's the community holistic services. People thought we were nuts 10 years ago when we were investing in service dog therapy and yoga and acupuncture and equine therapy, like they say, and you don't even ride the horse. Yeah, no kidding. It's about sort of a biofeedback loop between the veteran or the family member and that horse. And it's just an amazing thing to watch our veterans and family members benefit from that. And that can often then be the bridge to C4 at the top of the pyramid, which is clinical services. I will say that our community partner for clinical services here in New York City was the Headstrong project that started several years ago. It's now in 28 cities. They use EMDR, eye movement desensitization and reprocessing. They have a very integrative approach, and I think that over time, this approach is catching on within the VA as well as the military. And let me just close out by saying two things in terms of protective factors that give me just great hope and courage and strength and joy, really, to see the evolution. One is within the DoD, to see the work that Joe Geraci has been doing in terms of the ETS sponsorship program, to be able to connect with service members and their families in the 6 to 12 months before they separate from the service, and to be able to connect them with trained sponsors who are in the communities where they're going to be going. That's so exciting. We know that that's a protective factor, and we'll build on that going forward with all kinds of community partnerships. Moving to the VA, I have to say the whole health cultural transformation, the office now that you lead, the Veterans Experience, Lynda, this has been a game changer, and it didn't happen overnight. Certainly Secretary Bob, Secretary Shulkin, and now I gotta tell you, these last few years with Secretary Wilkie, to see what he did with Lynda Davis and of course Senator Dole, to just move heaven and earth on behalf of our caregivers, their families, the survivors. It's just awesome. And the kind of partnerships, and now the research center, and there's a lot to be very hopeful, to be very optimistic about. And I think that to continue this trend, we need to keep nudging our institutions and ourselves, because it may not come naturally for some of us, and we're stronger together in partnership. Back to you, Pierre.
Absolutely, yes. So, Doctor, and thank you for that commentary, Dr. Sutton. So, with respect to the initiatives that you, Dr. Davis, are overseeing, and because of your strong leaning towards that, I'm going to use your hand signal, this sort of integration of things with respect to the VA, what happens within the VA, and what happens with your community partners. Are there particular things that you're excited about with respect to the community partnerships that are currently in play or that are on deck to be deployed that will be of value to your members?
Thank you. That's a great question. And I know that all of us on this panel shared that appreciation for the important strength and role of the community. First, just Dr. Cahana, it's been an honor to work with IDF, especially IDFWO over the years in collaboration. So thank you for what you have taught us, especially about working with survivors. One of the things that we are doing not only is that whole health model that Dr. Sutton, Loree referred to, and what I see the customer experience is a driver. It is a driver. I want to take the results from our surveys and what we're hearing and the concerns, and I want to make sure those are driving our response and that they're public and that we are accountable. But a couple things that we're doing to ensure that community integration, because we know, I mentioned DoD and HHS ACL. We know we not only have to have federal agencies connected in that from accession to memorialization for the experience of the service member veteran inclusive, but we also have to do our state and local agencies and our nonprofits, our VSOs, our MSOs, our corporate strategic partners. One of the exciting things I'm challenging my staff is assume everything is virtual. And if you're going to do that, how do you ensure that we're maintaining and increasing the trust of the veterans, whether they get the service in VA or out in the community as we refer them? What we do when we measure trust, we have 3 metrics: ease of access, effectiveness of the service delivery, and emotional resonance. That emotional resonance to me is that connectedness that we're talking about right now. That is the essential special sauce that makes the experience totally different. So one of the things we're doing to put that virtualness and the engagement with the community in partnership, and also that ease and effectiveness, emotional resonance, is through our virtual Veteran Experience Action Centers. We had one last month in Florida. The entire state of Florida, veterans were notified that if they wanted to get care from the VA, if they had a concern about health care, and we're not talking about benefits very much now, but essential, our benefits experience and the delivery of that, your GI loans, your home loans, your pensions, that's key to your financial readiness and thus your wellness and your mental health. How they get memorial services and others. We put them all in a one-stop. We had gave veterans the opportunity to sign up for a phone call where they provided us with the information, the concerns they had. And just like we do these in real time in the communities in which they live, we took it virtual. We used all of the Jacksonville as the kind of staging base with the community veteran engagement boards, the state directors of Veterans Affairs, all of the local VSOs and MSOs, Wounded Warrior Project, United Way 211, all of the different church groups, and we had that veteran available with one call with warm handoffs. Okay, first, this is your concern about health care. You need an appointment. Here's where you go. This is your concern about your benefits and you're not getting them. This is your concerns about community support for your spouse who can't leave the house to buy groceries. Each one, and we addressed it comprehensively for that veteran in one phone call. And then we did the follow-up. My charge to my team is, with this collaborative model, being very mindful of that human interactive element, which is why we have the boots on the ground partners, go out and serve the veteran where they are, whatever they consider their need. It's not up to me to determine that their first priority is their diabetes or even their need to perhaps address their alcoholism. That doesn't matter. It is the veteran telling us what they need most, and then us addressing that in conjunction with the entire picture of what they and what their family needs to have that whole health or go from the illness to the wellness.
Wellness, excellent, Dr. Davis. Thank you very much for that commentary on the continuum. And Jackie, if I can sort of turn to you for a second, because you talked about wearing a few different hats, and that obviously of a veteran, a user of systems, etc. When you're talking to, or if you're talking to external providers who are looking to or currently engaged in providing service of different kinds to veterans with respect to their health, do you have any particular sort of points of advice, if you will, for how to level up and provide the kind of care that is necessary to actually drive great outcomes? So with any of your hats on, do you have a particular direction or set of suggestions for those community-based providers?
So I go back to one of my concerns is, and at one point I was trying to chart out when we encourage help-seeking behavior, and what does help-seeking behavior look like? And I think Lynda started to describe that a little bit. The veteran might not necessarily know or want to admit that they're an alcoholic or that they have PTSD or that they have diabetes. And the process, because help seeking is a process, whether it starts with a friend or very often a spouse saying, you need help, and actually taking the steps to go to the VA or go to a private provider or go seek inpatient care, there's a process that somebody goes to. There's also a process for how we offer help, and that I call help offering behavior. We spend a lot of time trying to reduce stigma around encouraging help-seeking behavior, and we put up posters and 800 numbers, and then we sit back in our chairs and we wait for the phone to ring. It's the help offering behavior that I think we could do a lot more with. When I was at DoD, we did a study with the National Guard, and we randomly called about 1,000 people that were on a list. I won't get into all of that, but we randomly called them, and 72% asked for some kind of assistance, whether it was how to find the VA or they needed an inpatient referral. We would not have known about them had we not called them. We didn't know they had any risk factors. We just didn't know because nobody was asking them. We weren't being proactive. So I like to think about the proactiveness. And when I was at DoD, we had created something called the Wellness Assessment Risk Nexus Calculator, the WARN. And it was using a predictive analytics model to look at things that were wellness factor risks across the 2.4 million active in Guard. We created, using a lot of the data that Rajiv was talking about earlier, taking all those different data sets and some federated learning and trying to merge some of that. So, and we randomly set very arbitrary looks at what we thought was risk for suicide, substance abuse, you know, that trajectory, the slippery slope of life, what I call the snowball, snowflakes, and avalanches. Where were these people along an XY axis? And we set XY as velocity of change and accumulation of risk. So if you're on your axis and you pull this top block and this top block, you can see your highest risk population. We were looking to take those data points, reconvert them into who were these people, actually create lists and start doing that outreach. And I think that's the key. It's not sitting back, putting up the posters, waiting for people to call you, because I'm not and some will argue with me, but I'm not a real believer in all the money that gets spent on awareness campaigns. Especially with suicide, because I think sometimes that normalizes the exact behavior we're trying to stop. So I think it's more in the help offering and looking at how we match our help offering behavior to help seeking behavior so that we find the patient before they even know they're a patient and mitigate and build their resilience, because there are a lot of very disenfranchised people out there within a lot of women suffering from domestic violence, African Americans, Hispanics, other people and minorities that don't have equal access to social justice, and they don't have equal access to healthcare. So we have this very disenfranchised population that we don't always get to see. They don't show up for town hall meetings. They're not the ones that we can easily find and plug into. So how do we step outside of our own comfort zone and offer them help by identifying these risk factors using a system like WARN, federated learning, predictive analytics? How do we take these new and emerging technologies that are there and bring them into the systems to better enable the systems? I would love to see the Veterans Benefits Administration, which we haven't really talked about, the VBA. I would love to see that automated. I would love to see that rating schedule automated, because I would rather see the VA employees who are raters and processing all these claims paperwork. I would like to see them become more like your financial planner, who calls you up and says, hey, did you know you're eligible for this benefit? Or I see you didn't take advantage of, and why don't we get you signed up? And why don't you learn about? We need the VBA should be more like a sales force for all those benefits and services, as opposed to waiting for people to call and apply.
But some of those I call them nudge programs, have been shown to be useful. I